Physio at Work podcast. In this podcast, we shed light on OH Physiotherapy and the important work that physiotherapists undertake in private and public organization, in education and society, in shaping the health of Britain. So this is a limited series of 10, maybe 12 episodes. We'll see how it goes, during which time we'll talk to experts in their field of work. And today's guest is Dr. Cameron Black, who's a physiotherapist working in occupational health in the NHS. And for our international viewers and listeners, the NHS is a national health service in the UK. So we want to achieve a better understanding of the work that OH physiotherapists undertake working in the NHS and understand knowledge, behaviors and skills and more. So Cameron, thank you so much for being on the Physio at Work podcast.
Thank you, and thanks for the invitation. I'm happy to talk to like-minded individuals and also get the information out there for anyone interested ultimately in physios in the workplace. So thank you, and thank you to ACPOHE.
Brilliant, thank you. So let us get a little framework to the session. Would you mind talking to us a little bit about yourself? Where do you come from? What was your path to ending up in the NHS working as an OH physiotherapist?
So I'm originally from Belfast and I did a 4-year degree. That last year of the degree was kind of a lot of postgrad stuff, and I think a lot of the 4-year degrees now have finished within the UK, but qualified in 2009, a physiotherapist obviously by background, and kind of fell into occupational health by accident. So I went down the line of musculoskeletal physio, sports. 2009 wasn't a great time generally for the well-being of the nation. We went through the financial banking crisis, and I remember vividly in university the lecturers saying there ain't going to be a lot of jobs when we qualified. So immediately, and it was a big cohort in my class, about 20 left to do other healthcare professions, 20 left to do other professions in general study, so banking, different areas, and the ones that were left thought we need to go overseas because there weren't many jobs in the UK. So I ended up in Singapore and I worked there for nearly 4 or 5 years, I think, and did rotations. But I've always found myself kind of drawn into roles where I felt like I could influence kind of prevention and generally the workplace. So I always nominated myself to do any of the workplace stuff, any contracts that we have. I worked in a big public hospital and was always interested in this workplace angle. So circa now, what are we, 2025, this interface between work and health relationship, I would see myself as a clinical academic or developing into a clinical academic and trying to better understand this work and health relationship and this reciprocal relationship between work and health. The two can influence one another. How jobs generally affect people kind of physically and mentally. And I felt like that interest possibly led me naturally then into occupational health, because it's one of the few areas that I see that where you can get to combine kind of clinical care, bigger system thinking, and then the public health aspect, which I think all physios should be interested in. So that combination is really, really appealing. And if you do have interest in that or the interest of trying to combine them, I think occupational health is a great fit for that.
Yeah. So you came back from Singapore and started then working in the NHS?
So I did a master's. So I was in sports, professional sport. I was up in Scotland, did a sports and exercise science and medicine MSc, worked at the Institute of Sport for a while, some private practice, and then I started locuming. One of the contracts was with a big manufacturing company, which was a whistle-stop tour of occupational health physiotherapy and the demands. And I think that was the footing really for the career, which that was 2017-18. So that was a baptism of fire with regards to the demands of manufacturing. Obviously for them, everything is in terms of critical infrastructure and on-time demand for equipment and everything else that they delivered on. Time is money, etc., etc. That was my grounding really, and that was my foot in the door. And then 2020, I started working in the NHS, which is an interesting time, which was COVID times. So I started physiotherapy within the NHS, and then quickly with COVID, clinics, like many people potentially on today's meeting, were shut down, so we didn't do face-to-face stuff, and I was redeployed within functions of the organisation that they deemed critical. So trying to understand how we could redeploy clinical teams to areas of most need, and part of that was risk assessment approach, which was totally alien to me. But the good thing about public healthcare and also working in the NHS is we have expert teams, so we all came together to try to redeploy people, where needed, and occupational health gave an opinion on this risk assessment approach that was required at that time. So another baptism of fire with regards to starting in an organization, COVID hitting 2-3 years down the line. Around that time I'd just finished a doctorate as well, so the studies looked at primary care, so a core set of occupational health competencies for first contact practitioners. So anyone not in the UK, FCPs or physios by background, albeit that there's other healthcare professionals that can do the role as well, in primary care, managing MSK, and they were legislated for the fit note in 2022. So the doctorate looked at the kind of learning and development needs of these people, and also just the wider consideration of how to avoid kind of sickness absence. So we knew the fit note wasn't working. My interest was, how do we get other healthcare professionals to pick it up and run with it ultimately, because I do think that these excellent healthcare professionals can do it. We know the challenges involved, but so that was, and then since then that's where I'm working really. So my role is quite broad. Individual assessments currently in the NHS, rehabilitation, workplace assessments, but also the wider piece, service innovation, looking at digital transformation, also involved in some training aspects, supporting other professionals and trying to build on the research that I've done. So very keen on taking students as well, so trying to impart the knowledge and skills needed in this area to students, because I think students don't often have the ability to have occupational health placements, which I think is a shame. So we're always keen on taking students, and they've added great value to the service, within my service, both clinically and also the wider prevention pieces as well.
Yeah, so I used to work in Coventry City Council, and one of the things we did was to take on students so they could get experience in occupational health. I think it's quite unique.
So I think I'm obviously embedded in the NHS, and I'm conscious there's other people working kind of independently, and the common theme that we have though generally is that we're key enablers of this notion of kind of workability. So whether we're in public health or we're standalone, and kudos to those standalone independent providers, the models possibly differ, but the outcome ultimately is the same, is that we're trying to keep and help people in work, stay healthy, and ultimately thrive in
Yeah.
work.
So could you tell us about the typical day in your working life?
Mm. So, as I said, I work in the NHS. So day-to-day life really is leading on musculoskeletal health within the workplace. We're a kind of a medium-sized NHS trust, so over 7,000 staff. So we see face-to-face through self-referral or management referral, and then obviously the documentation related to management referrals. But we also contribute to the wider wellbeing and prevention initiatives. So we have an established wellbeing team, and the trust that I work in is rated very highly with regards to national staff surveys for wellbeing. So as I said, my role is quite broad. A day-to-day life could look at individual assessments, whether that's function, whether that's someone with dealing with a recent injury, or post-surgery, looking potentially at rehab needs as well, especially if they haven't seen their local primary care provider or secondary care provider, with regards to physiotherapy. And then when it's kind of deemed necessary, workplace assessments, and then all the other stuff that I talked about, service innovation, digital methods of innovation. So with AI and the digital side increasing, we're looking at ways that could be harnessed. But that, I think that at this stage, that human element is so vitally important. When we talk about workability, when we talk about fitness for work or returning to work, it's always that human connection. It's always that coaching approach to recovery and trying to keep people well in work, that I think sets physios apart really from others.
Yeah. In terms of like the workplace assessments,
Mm.
would you go out on the ward and assess
Mm.
employees, nurses, doctors, physios undertaking the job? Or is it largely
Mm.
like office-based DSC assessments and so forth?
Mm. Yeah, we would do both, depending on needs, sometimes management, and sometimes when you have a grand plan of thinking this is what I think is needed, and you go out, and ultimately what's needed is just good communication between the stakeholders that are involved, either reinforcing training or ways of working in a positive way with regards to, yep, you're doing excellently, we feel that you're safe, it's just the case that you need to build or continue on this current path in terms of recovery. So I think sometimes individual employees, having that person there to talk to, ultimately taking them out or speaking to them while they're doing the job, I think is key. In other areas of occupational health physiotherapy, but possibly it would be very kind of more specific with regards to the way people move, the way people lift, the way people do things. Whereas for us, where I work, I see us more of a bridge between manager, employee, and the kind of system. So it's more of a support with regard. There is specific information advice that we weave into documentation, or maybe after a workplace assessment we would formalize through a report. But generally, I find recently, and maybe it's just a recent thing, but it's more that giving that employee confidence to stay well in work, and there may be some tweaks, but generally, as long as everything is in place and we feel that we've given right advice at the time with regards to the hours or what they're doing, based on their kind of job description, ultimately, it's about giving them time to recover.
Are you also involved with the helping people back to work?
Mm.
And I guess you were mentioning the fit note earlier.
Mm.
Are you involved in advising on fitness to work through the fit note
Mm.
system?
No, so we would, in terms of policy, obviously it would be a requirement. The vast majority of NHS trusts, I'm sure, would require through policy, when someone is ill after 7 days, to have a fit note. So we wouldn't tend to get involved in giving fit notes. I would encourage any physio who's not in occupational health services to provide fit notes if you can, and especially weaving in positive work advice with regards to recovery, if you feel like it's indicated. There are people obviously that are not fit for work, but we want to change the metrics with regards to fitness for work, and especially fit with adjustments in work. So I wouldn't. There's probably an argument to say that formal occupational health documentation would kind of supersede fit note, or give a differing opinion. Possibly, we would be seen as the work experts, and we understand the work that people do. We understand the jobs that people do. So I think generally we would be seen as having a good opinion on whether we thought the person was fit or not. That would obviously be based on a full functional examination, seeing someone face to face, but also having acute knowledge of what people do ultimately, whereas the challenges involved in giving a fit note within 10 minutes is numerous, especially when you're in a busy clinic. So we have some sympathy for other healthcare professionals that are given fit notes, but if there's any discrepancy or there's any concern, I would always recommend that people are reviewed by Occupational Health. We should be seen as a supportive service with regards to what people do. We don't tend to force people into work, or it's not a kind of us and them. It's a we'd like to hope that the vast majority of stakeholders want the same thing, which is supporting someone in work and helping them recover while they have an injury or illness. For us as physios, that tends to be musculoskeletal, but as we well know, people are living with long-term health conditions, and things can become complex, or mental health presentations. So yeah, so I wouldn't. I have done in the past, but we wouldn't. It probably be seen as a conflict with regards to providing those. We would formally document, and then it would be up to management to decide whether what we've documented is reasonable and can be accommodated within the workplace.
Yeah. I think physiotherapists are in occupational health is uniquely positioned to helping with helping people return to work, and I think we would help to offload GP services by taking on more of the fit notes bits of health services. Now, in terms of the type of people you see, what type of conditions? Back pain, neck pain?
So it can vary massively. I mean, what do we know? 22nd of April, Easter weekend, bank holidays have just been. So coming up is the London Marathon. So I got two emails this morning from a staff nurse and a consultant, both running London Marathon for charity. So one's got a niggling kind of knee presentation, and another I think had a ankle sprain. So for both, we're going to see if we can get them through with regards to getting them through the event. So it could be that. We see a full range of NHS staff, so from porters to consultants. So common injuries, really low back pain, very similar to how people present across the population. So repetitive type presentations. Some injuries, although they're rare within the workplace. Often some other comorbidities as well, so mental health presentations. So generally the process would be self-referral, and I would have a low threshold to see people. I can understand the challenges in terms of capacity, but you know, it could be an assessment and that's it, you know, and we give prescriptive advice and so I would have a low threshold to see anyone with any concern, because generally I find that people tend to know best, but referrals could come from work specific, HR, obviously managers. Sometimes we have employees referring as well when they have work related concerns, if there's things that they're doing in work that they have concerns about manual handling, or you know, I've come back post injury or surgery, I'm not quite sure about X, Y, and Z. So I would always recommend that we see those people, and then if it's not indicated, onwardly refer, because we do have an extensive support network as well with regards to our nursing colleagues, mental health nurse, occupational health physician. So within the service that I am involved in, we use a lot of education advice, documentation related to work, recommendations.
Hands off, like a
So
hands off approach or hands on?
It depends really. Could be both. We tend to think, and I'm conscious because there may be others within an NHS setting, much larger trusts than us. You know, double some of the Birmingham and London trusts, probably 15,000 employees, more possibly 20. I'd recommend potentially initially a self-management approach and strategy to recovery if it's indicated, but sometimes manual therapy and treatment, in terms of helping people recover, as an adjunct. But the goal really is always to keep or get people back to work ultimately safely, or if they're in work, trying to maintain productivity and confidence in the work that they do. So treatment often, if it is hands-on, is always focused on the work elements, but also in terms of the rehab aspects, very functional as well with regards to the work that they do.
That's really interesting. And in terms of turnover of staff, you know, would it be like 1, 2, 3 sessions, or does it vary?
It on average, probably 2 to 3. I think it's quite difficult. It's probably quite difficult in general across the population to take someone. If we look at the research in the primary literature, the latest information on back pain, and you know, Professor Peter O'Sullivan's staff and cognitive functional approach to recovery, they recommend X amount of sessions over hours and hours. Ultimately, it's difficult to take someone on a full journey, with regards to 4, 6, 8, 10 sessions. We tend to involve, if something is needed with regards to more intensity, we would tend to involve the local secondary care provider, and then we would pick them up at regular intervals. But yeah, I would say the average is probably 2 to 3. For some people, we see them more. We've got an open referral system, so no one's really discharged. We just, if they want to email or get in touch or email our occupational health team admin, they can see one of us within our KPIs, hopefully, so they can see someone within a few days. And then the management side within a week, 10 days to document. So I think that's always the challenge, that challenge of you know, seeing the people you need to see for the number of sessions that you need to see them, but also being acutely aware of not overburdening the system, because if you take everyone on a journey, you'll find that the worry is for you as a clinician is burnout, but also you just don't have the capacity. So it's trying to add most value in a system that ultimately work is the focus. So there has to be an element of self-management in terms of from the musculoskeletal side. But that's a difficult balance. I appreciate that others, may weigh heavily on the treatment side, or others may weigh heavily purely focused on the work side. We try to juggle and put different hats on with regards to the therapeutic side and the occupational health side. But purely occupational health physiotherapy ethically would be, judge, jury, executioner rather than patient centered only.
Yes.
So
How about mental health? So you're
mm,
mentioning that mental health is also a feature in our job and
mm,
the clients that we see.
mm,
Uh, Stress, mental health problems, perhaps considered to be secondary or sometimes primary
mm,
problems,
mm,
and the musculoskeletal side sort of comes out as a
mm.
secondary issue. Is that something you are experiencing?
Yeah, I think we can see patterns ultimately, and I think we're very very good, especially ultimately the statistics don't lie with regards to referrals, and if we're seeing individuals being referred consistently, generally there's some other prognostic factor with regards to why is this the case ultimately. You know, is it a work problem? Is it a stress, mental health type presentation? Um, what I would suggest really for all of us is, even in physios, and we, I have a colleague who's a mental health nurse, and her focus is in supporting people with mental health presentations in work. So I wouldn't say that we're treating with regard to that, but I do feel that physiotherapists do have the ability to see the big picture ultimately, in terms of treating people holistically, but also seeing many presentations, whether that's musculoskeletal or mental health presentations, as common health problems, and
Mm.
understanding basically their functional effects. So whether it's stress, anxiety, um, osteoarthritis, specific clinical conditions, how people present. Ultimately, the hallmarks of that, especially when we consider the work elements, what we need to do ultimately is understand human nature and behavior, and ultimately it requires a good grasp of human nature, whereas a purely health and safety approach doesn't quite cut it with regards to either supporting someone in work. There's probably a deeper understanding required, and I think physios are really good at that, understanding the effect, and looking at someone holistically. If we treat only, if we take someone out of the workplace, it generally has little impact on work outcomes. So if we treat in isolation, if that's stress, anxiety, um, it it can actually act as a barrier. So what we have to see, sorry, is any mental health or any musculoskeletal presentation. Now we can discuss about risk and triage and different aspects, but generally, the vast majority of people that present are kind of low to moderate risk, and
Mm.
we need to probably view those people as having common health problems. And where we come in ultimately is understanding that, but also co-producing a plan ultimately that works for them, and that's the hallmarks of occupational health and occupational health physiotherapy, which is what are the strategies. So temporary provision of modified work, or adjustments, or other flexibility in terms of hours that people work. But if we want to change the work outcome, we need to talk about work ultimately, whether that's a mental health presentation or a physical health presentation.
Yes. And you also alluding to working in a larger team, whilst many physios might be working on their own.
Mm,
So their reality might be slightly different. They wouldn't have
mm,
the opportunity to refer onwards. So would you say that you as part of your job, you will identify these different flags and perhaps refer onwards, or would you also take on the management of some aspects of these conditions, thinking in terms of anxiety, depression, similar?
Yeah, we would definitely assess and probably apply some validated outcome measures where they exist, but ultimately what I find generally is speaking to individuals, and we get a good story, we get a good history with regards to the journey that they're on, whether that's someone who is in a difficult place in their life or work. So yeah, there is an element, there will always be this notion of assessing flags. It's so vitally important, but like any outcome measure, it's kind of, so what, what do you do with that information? Does it change the clinical picture? And really then the importance of coaching, what do we do? How do we co-produce something that works? And really that's the planning element and goal setting, and ultimately seeing physios as coaches and excellent really communicators, positive communicators that are focused on work outcomes, really. So that the more you get exposed to picking up patterns, it's kind of experiential learning. So the more people that you see, you can understand the effect that injuries and illnesses have on people and the work that they do. We are experts in musculoskeletal presentations. We're experts, we can diagnose. We're experts in terms of rehabilitation. We understand the effects that injuries and illnesses have on people. So that timeline of coming back to work within 7 days may or may not be applicable, or 6 weeks, or whatever it might be. I think we're very good at understanding, the patient position, but also understanding that the business, there's obligations to the business as well. They want an employee that's productive. So there has to be an acute appreciation of the flag network, and coming into that, for those that maybe work in musculoskeletal settings, it's not too dissimilar to, say, sports medicine, where you have the athlete in front of you, you have the manager, you have the coach. So there's a lot of stakeholders, there's a lot of conflicts of interest, and that's the same in the business environment. You have the employee, you have HR, you have their line manager, and everyone else potentially has a different opinion. So where we sit ultimately is the go-between, trying to get all those stakeholders on the same page to say, look, we want this athlete back in the pitch, we want this employee back to work and supported in work. How do we make it happen? What's reasonable for them? And this is what I think is required. So there's a little bit of a negotiation and a little bit of give and take from all of us. But yeah, we work where life happens, and generally the vast majority of us on this call, that tends to be in our waking hours, that is work. So the common theme that we have is work. So I always get people to talk about work and its impact on you and your life. But talking through some of those challenges with people, with regards to the obligations, legal obligations, in terms of stress, we have stress risk assessments, but I think it's a good way to formulate conversations, in a non-judgmental way, and in a way that's supporting recovery and giving people dignity and purpose, rather than accusatory or, this is how it is, etc., etc. So to understand that, potentially when you're working as an MSK physio in an outpatient setting, the notion of blue flags, black flags, the work elements, I would always challenge, so what do we do about it? We understand these are challenges or barriers. How do we navigate them?
I think we're coming towards the end of these 45 minutes. That's been slimmed down a little bit because of technical difficulties. But I was wondering whether we could end on this note or theme. So I'll be interested in your particular view on what physiotherapy and occupational health is, like a unique interpretation of your role. So my thoughts around it, sounds a bit pompous perhaps, is that we're a bit like the mom and dads of the organization, problem solvers, reassurers. When there's conflict, we're there to help settle any conflicts and to help make things work as a third party. What would be your thoughts on that?
So I think we've talked before, Lasse. I would say we're the Swiss Army knives of this area in terms of work and health. We're really good at doing everything. We're the connectors ultimately, and we kind of build bridges across departments in terms of creating healthier workplaces or more resilient staff or more sustainable systems. And I would have great confidence in potentially the majority of people on this call. Maybe they lack the confidence, but I would have confidence in them to give accurate advice, which is generally evidence-based on work and health and that relationship. So I would say that physios kind of see work as not part of the problem, but as the solution as well. So this notion of workability and trying to see work as rehabilitation. And the challenge for us is to negotiate kind of stepping outside of the treatment room and into the factories, the hospital wards, the kitchens, the boardrooms, wherever people do the work that they do. So we do have elements, the therapeutic side of treating people and helping people, but I'd like to hope that we prevent problems before they start. So keeping people working, keeping them moving, thriving. And to do that ultimately within the area that you're in is a big challenge, because there'll be cultural issues, there'll be system issues. So we need to see the change in there. I'd love to see physios trying to influence policy and speak up for the health of the workforce. So I think occupational health physiotherapy is ultimately deeply human. It's about that human element. It's the main root of enabling people to work. That coaching element, the communication, the ability for people to navigate conflicts. I would say the vast majority of physios are there. They're in the background maybe, so we need to sing and dance a little bit more. But generally physios are there quietly preventing. They're listening to people, they're adapting, they're solving. What we need to get better at is getting that information out there. So getting out the case studies, seeing the person behind the injury, the wider teams behind the admin desk, the story. What's the story behind sickness absence? What's the big trigger? Because the wider thing, and this is where the research hat comes on, is the wider drivers are basically workforce. They're the economy, they're society. So if we look at the numbers currently not working due to ill health and the number of people with disabilities leaving the workplace, we want physios to better support those people to stay in the workplace. So don't wait. My challenge for people is don't wait for people to break.
That's really good. Thank you so much, Cameron. I think that'll be a good place to end today's conversation and podcast episode. Thank you so much for doing this for us. Much appreciated. And I wish you all the best for the future, man.
Thank you. I'm not sure what facial expressions I had at the end there, but I got a big black screen. So I was like, what? I thought it was the end of civilization as we know it.